All right, everyone, welcome. Tonight we're going to be doing cranial conundrums, clinical pearls for cranial or intracranial disease. Dr. Sowka is going to be our speaker. Joe is working currently for Center for Sight in USI. Joe was a former teacher at Nova Southeastern in South Florida there in Fort Lauderdale for 28 years and 2 days, I believe is the exact count that
That
Joe
is
was
correct.
there. Joe helped launch that school. Joe was in retina and glaucoma. Joe's a prolific writer. He's a great writer. I take something and write it and think it's good. Give it to Joe for 5 minutes and it comes back as almost he chat GPT'd it. But he's also a great lecturer. His passion is neuro. He's got lots of knowledge in all other arenas, but his passion over the last few years has been neuro, and he's going to highlight that tonight with cranial conundrums and clinical pearls. Not only is he a great lecturer, he's a great friend, great partner. Joe, take it away.
Well, thanks, Craig. I'm certainly happy to be here and doing this with you. So it is neural. If I get into the weeds a little bit, I want you to pull me back. If you can police the chat, or if you have your own thoughts or questions, please don't hesitate. I don't want to just go one long sentence for the next hour and 40 minutes, which we can easily do. I want to keep it a little bit lighter and brighter and make sure people get the pearls that they need here. Now, these are my disclosures. In the past 24 months, I have been on the Speakers Bureau for Bausch and Lomb, I guess Bausch Health. All disclosures have been mitigated, and along with Greg, I am a co-owner of Optometric Education Consultants. I also want to say again, I always like to preface this. I work in a large medical surgical practice. I'm not in an academic referral center or college optometry. I book 25 to 30 patients a day, primary care, glaucoma, corneal disease, emergencies, and contact lenses. And I do the neuro ophthalmology in our practice. And I get the referrals from our optometrist and ophthalmologist, and also from our outside referral services. And I function pretty much here, as everybody here does. I don't have 2 hours to do a neuro op evaluation. I have to think quick. I've got to move quick. There's a lot of work after the fact, after the patient's seen, when we get the imaging back, the serology back. We have to make the connections, the follow-up, but it's not a 2 hour evaluation for me. I'm moving very quickly. Hopefully I'll get an easy 1 day post-op or a simple refraction as the next patient so I can get caught up. Now, the question might be, why do neuro eye disease? Why do neuro op? Well, it is a financially rewarding specialty. Yeah, said nobody ever. If we start, I mean, I'll be honest, what I do is a convenience in my practice. I don't financially move the needle, but I am a convenience, and I'm the place where when people have questions or these neuro op emergencies or situations, they know that I will take over the patient and try to give them the best care possible. Now, if we look at the risk involved, we see that the number of claims per specialty in OMEG data is relatively low for neuro-op, but when we look at the indemnity, how much payouts, it is probably the highest. There are not enough neuro-ophthalmologists out there. There's only 45 fellowship spots and only 25 filled last year. They need boots on the ground, and they are embracing optometry and osteopathic medicine and physician assistants and neurologists. In fact, it is a common practice for neuro-ophthalmologists to be looking to hire optometrists for their practice. It can be a high-risk situation. These patients do have a tendency to want to get sick and die. Interesting. I had one of my referrals today was from our retinal specialist. He said he was 99% sure that he had the answer to something, but he wanted me to give the final blessing to make sure that he wasn't missing anything neuro-ophthalmically, and he was not. He was spot on. And we have to think back to our training, our fellowship, our residencies in school, and we have to think: is this urgent, or can it wait? Is it something I should be doing more for? Am I overreacting? Am I moving appropriately on this? And it can sometimes be complicated. We have to have at least a basic understanding of neuroanatomy. In many cases, we don't, or I don't, form a long bond with these patients like I do with glaucoma patients. When I was at university running a glaucoma service, I'd be seeing patients for 20 years. And these neuro-op patients is diagnose and adios. Make the diagnosis and work with the proper medical specialist to get them taken care of. And this can be schedule busting. Uh, Virtually 100% of the time, if one of the optometrists or ophthalmologists in our practice or anybody in the referral network contacts me and says, I've got a patient, can you see him right now? Virtually 100% of the time, if I'm in the office, I'm going to say yes, and send him over and I'll figure it out later. Hopefully, again, it'll have been easy one day post-op to help balance things. There's no level 6 or level 7 codes for what I do. I can bill fairly highly because there's a lot of complexity, but there's a limit. There's no RVUs or bonus if you save a patient's life. But ultimately, and this is from our friend Dr. Andy Lee, neuro-ophthalmology saves lives. So if you know this material and you can intercede with these patients, you can save a life. There's no question about it. Well, you may think, well, when in doubt, just send it to the ER. They always get it right, right? Well, here's a nice case to underscore the point where you don't want to necessarily just want to be dumping these patients. He was a 36-year-old male who presents suddenly with painless loss of vision in his left eye of one day. He's 20/20 in the right eye, 2200 in the left eye. He's got a relative afferent pupil defect. He is a diabetic, poorly controlled. And I've always said, when you have younger patients like this, it really is something really bad or really stupid. But he's a young person who's got sudden vision loss. And we take a look and we can see that he's got some diabetic retinopathy in both eyes, but there's a profound disc swelling, very acute based upon the hemorrhagic and exudative nature of this. We can see there's a lot of fluid coming through from the disc, separating the retina, even separating from the RPE. So here's a young person who's got a sudden onset neuropathy. Now, the differential diagnosis is relatively comprehensive. Could be infectious, can be infiltrative, can be inflammatory, can be demyelinating, can be corrosive. But I'm thinking, among other things, first, inflammatory, infectious, or infiltrative. So evaluation, I'm going to order on this person MRI brain with and without contrast, and MRI the orbits and chiasm with contrast, and fat suppression for the orbit. Going to order CBC, Cedrate, CRP, ANA, RPR, FTABS, ACE, Zoster, rubella, toxoplasmosis, Lyme, Bartonella, both Hensley and Quintana, P. Ankin, C. Anka, looking for the vasculitises, looking for infectious diseases. This is one of my strong suspicions would be infectious in this case. Now, he also has some diabetic retinopathy. He has some edema, so we also do a concurrent referral to our retinal specialist for the diabetes. Well, he doesn't go to the imaging center. He doesn't follow up with the MRI. He doesn't follow up with the serology, but he did follow up with a retinal specialist. And at that point, he had not obtained any of the testing that I had recommended or ordered up. And he does not play around. He said, if you're not going to listen, you're going to go right to the ER. So he sent him to the ER. And their ophthalmologist on call was a resident who did a CBC, which was normal, except glucose was elevated, decides the patient only has diabetic retinopathy and doesn't need an MRI. And this is what a resident ophthalmologist is now telling our fellowship Bascom-Palmer trained retinal specialist. It's just diabetic retinopathy. I think we all know. And this is a patient who was ultimately lost to follow-up. So don't be dumping these people in the ER without help. They often will not get it right. And I'm going to share with you, Greg, I don't know if I ever told you this story, but there's a story about this older man, and I learned this from a friend of mine who's an ophthalmologist, and he was talking about ophthalmology training. And he was underscoring that in your first day of residency, they consider you to be an ophthalmologist. You don't know anything. Yesterday you were a med student, but now you're an ophthalmologist. So he's told about a person in his residency class, and I'm going to put it in quotation marks, and it may have been him, may have happened to him. But he told me about somebody in his residency class, first week of ophthalmology residency, he had to cover the ER. So an older man comes in with orbital pain. He kind of works his way through, checks pressure with a tonal pen, and finds out the pressure's in the 70s in the eye. So he goes back to his manual, reads through everything, and goes back and gives him some glaucoma medicines in the eye. And after an hour, the pressure doesn't really change. So he goes back to his handbook and flips through, and now goes back and gives him some oral Diamox. Pressure doesn't go down. So he goes back to his book and flips through in the handbook, and now he goes back and admits the patient for IV mannitol overnight. Well, next morning he was making rounds with the third-year ophthalmology resident. Third-year ophthalmology resident removed the prosthetic eye, cleaned it, put it back, and quietly said to the first-year resident, "You can release him now. He's going to be fine." So be careful of what you're going to end up with in the emergency room. If you're going to do that, you have to be willing to help them out. First patient I want to talk about, I guess second patient, is a 60-year-old male who comes urgently for a visual disturbance following a severe migraine. He had gone to the hospital emergency room where they got a CT of the head without contrast, which was normal. Now, Greg, why did they do that? Why did they do a CT of his head?
Because that's what emergency rooms do, basically looking for acute problems, but that's just what they do.
Yeah, that's what they do. To them, everything is the nail because they have a hammer. Everybody with a problem in the visual system is going to get a non-contrast enhanced CT of the head because they're looking for hemorrhagic stroke. And if they don't find it, they pretty much tap out. Now they may move on. There may be specialists to consult, but generally there's not. Well, he refused an MRI and left against medical advice. Now he's got double vision, mostly horizontal and with a vertical component. So I guess maybe we can say it was diagonal diplopia. Extreme head pain, right periorbital region, happened very suddenly. His double vision developed one day after his headache and periorbital pain developed. Neither are getting worse or improving. It's just very constant. So we're talking about 2 or 3 days into this. No fatigue, no vision loss, no nausea, no vomiting, no malaise, no lethargy. Mentation is okay, not confused. He's got no PCP. His blood pressure is modestly elevated systolically. So let's take a look at him. Well, he's 20/15 in each eye, no pupil defect. Optic disc, retinas are normal, normal cupping, and here is his visual fields, which were perfectly fine. Now let's look at his motility. Okay, looking left is good. Looking right is not good. He's got an abduction deficit, maybe a little bit of elevation deficit. So horizontal component, let's take a look over here. Now the alternate cover test. Pronounced right hyper. Worsen left gaze. Not quite as bad in right gaze. And I can tell you I don't have it here, but I also did a head tilt and is worse on right head tilt and improved on left head tilt. So he's got a 6th nerve paresis. He's got a 4th nerve paresis. So Greg, that brings me to polling question number 1. What is the likely problem going on here? Does he have a mass lesion? Does he have an aneurysm? Does he have ischemia? Or does he have inflammation? And while you're doing that, I'll just show the videos again.
I was just checking the questions out because usually you do that, and I was slacking my duty. Nothing is in there.
Oh, so abduction deficit in the right eye, hyperdeviation in the right eye. So there's his horizontal and vertical diplopia. And I assume the responses are coming in, Greg?
Yep, they are. So we can do display. We have 17% saying mass lesion. We have 31% saying aneurysm. Ischemic is 43%. Inflammatory is 9. So your two winners are C ischemia 41, aneurysm at 33, and about a tie for mass and inflammation.
All right. Well, let's think about where we're going to have the problem. He's got 4, he's got 6. And where 4 and 6 going to come together? Either the posterior orbit or the cavernous sinus, usually the anterior cavernous sinus. All right, so things that happen are painful and fast. We got to consider aneurysm, but aneurysms within the cavernous sinus are actually relatively protected. Those are not the fatal type of aneurysm because a rupture will lead to a cavernous sinus fistula, but not a subarachnoid hemorrhage, which will kill them. Ischemia can be very painful, but this is really, really painful. So to me, things are acute and painful and multiple neuropathies. I am actually going to strongly think about the least likely what people chose was inflammation. So what do we need? We need MRI brain orbits and chiasm with gadolinium and fat suppression. Sed-rate C-reactive protein platelets for giant cell arteritis. And even though it's painful, we still have to consider myasthenia gravis. So what I put on the note was 6 nerve palsy. I can only put one diagnosis down. Urgency, stat, attention, right cavernous sinus, paracellular area, rule out intracavernous aneurysm, cavernous sinus and posterior orbital inflammation, and pituitary apoplexy. Contrast both brain and orbital images, fat suppression for orbits. And I actually type all this out to help the neuroradiologist, the radiologist, know what to look for because I'm really thinking out loud on this, telling him or her what I want them to look for specifically. Now, again, we had some difficulty MRI scheduling. The first available with the imaging center and the patient's schedule was 2 weeks later. And I have to negotiate with the center and with it's not the Greg, it's not the exams that are hard. It's not the patient care that's hard. It's all the other stuff around it like this. Now, I hate playing radiology, let's make a deal. Try to cut deals to get the patient the care they need that maybe save their lives. So I finally get it up to 48 hours, even though he's got like a devastating head pain. All right, so we get it, comes back, abnormal enhancement, right orbital apex, right orbital superior fissure, right esotropia. Infection could be possible, unlikely given lack of other inflammatory changes. Inflammatory etiology such as Tolosa Hunt possible, but this is a diagnosis of exclusion. Neoplastic possible, less likely. Could perform further workup of MRA circular Willis and short-term follow-up MRI orbits with and without gadolinium. They of course contacted me with some information. So what we're dealing with likely, and I know he did need, we needed to do more evaluation. He needs a chest x-ray. He needs to be tested for sarcoid, but likely we're dealing with Tolosa-Hunt syndrome. So this was inflammatory. And why did I think it was inflammatory? The severe pain and the suddenness of the onset. Ultimately initiated 60 milligrams of oral prednisone because he's been suffering for about a week now. He felt better pretty rapidly. His diplopia persisted for a little bit, according to him. Now, the issue here in Tolosa Hunt is a rare disease. It's actually considered a rare disease. And the steroid taper can be very difficult because they have a tendency to rebound. So I don't want to try to force gut my way through this, I decided to work him into our neuro-ophthalmologist that is in our town as a favor, and he was willing to see the patient within the next 48 hours because he had a little bit more experience in the steroid taper. Our retinal specialist even said he's never even seen or treated one of these before. No shows. And when I contact him about it, he said, "Look, I got a business to run. Yeah, the schedule's not convenient for me." So, okay, Greg, you can't save them all. But what is Tolosa Hunt? It's a severe unilateral periorbital headache with painful ophthalmia. And that's what it is, painful ophthalmoparesis. NORD, National Organization of Rare Disorders, says this is a rare disorder. It's only one case per million. So literally he was 1 in a million. We can probably title this one in a million. Non-specific inflammation in the cavernous sinus, usually anterior cavernous sinus, bleeding over into the superior orbital fissure. Now, there's usually no systemic inflammatory disease, no concurrent infection or autoimmune disease. Can sometimes be misdiagnosed for neurosarcoid. So more evaluation would have been necessary, but he never really followed through. Now, the IHS criteria for this is a unilateral headache, which also includes granulose inflammation of the cavernous sinus, superior orbital fissure, either by biopsy or MRI, palsies or one or more of the cranial nerves, 3, 4, or 6 on the same side, which follows a headache within about 2 weeks or less, or usually develops about the same time. And the headache is really around the eye on the same side, and if you do an evaluation, there's no better other etiology for the headache. So that's how we diagnose it. Very responsive to steroid, dramatic improvement in pain with oral steroids. The ophthalmoparesis can be slower to resolve. They do have a tendency to go into a brief remission, then exacerbation. So that steroid taper can be actually very challenging. They can spontaneously resolve. But we don't, it's such an uncommon situation. We don't have a lot of recommendations about dosing or duration or how to do it. High dose therapy for a few days by a gradual taper over several weeks to month. Inflammatory orbital pseudotumor, very similar type of condition. Inflammatory disease, painful, abrupt. Well, we got some good news and some bad news. He never went to neuro, as I said, but he did come back to me relatively recently, Greg, after about a year and a half. The reason he came back is he likes me as his eye doctor, and he was very happy with his care. The steroids I gave him relieved his headache and diplopia pretty quickly, but now he is complaining of painless loss of vision in his left eye. Keep in mind, this was all previously on the right eye. And what do we see there? He's got a nice little cotton wool spot and a branch retinal artery occlusion. So it's now off to the stroke unit. And, he just sighed at that when I told him what I wanted him to do. And Greg, I don't know if he ever went or not. I've not followed up. You can lead a horse to water. You can even sugar the water, but you can't always make him drink. And if it wasn't for bad luck, I guess you have no luck at all. Tolosa Hunt syndrome, then a branch artery occlusion. Any thoughts here, Greg?
No, I mean, it's unfortunate he didn't get followed up. I mean, no thoughts on the case. Just unfortunate he didn't follow up. He's definitely got something going on in that body that needs to be addressed, or it's just going to lead to something bigger and worse, bigger and
And
better.
I
I don't
think
want to
there's
say
probably,
better.
I do think they're two separate things altogether. Anything in the
Yeah,
chat,
I mean, they're two
Greg?
separate, but he's got something going on. I mean, geez, he's got an artery occlusion. He's closing
Mhm,
off vascular. He's got an inflammatory process. So there's a bigger problem out here, even though they might be unrelated. So,
mhm. Anything in the chat?
nope, we're all good. So,
All right. Well, here's one I call the post-op red eye. This was actually when I left university, went into a medical surge practice. This is actually one of my first on-call weeks that I had. And I actually didn't even see him directly. He was a 73-year-old male who had cataract and mild glaucoma. And the day before, he had a cataract removal with implant and an eye stent. Now I'm on call. He's not my patient. He's the patient of another optometrist and ophthalmologist in our practice. And I get a call at 6:30 in the morning, and he's really pretty calm. He said, I woke up and my eye was all red, which I'm not overly concerned by that. Having a red, but really what he meant was not his external eye was red so much, but his internal eye was red. He said, I can't really see it. It's getting a little bit better, but when I woke up, I really couldn't see at all. So what I have learned when I'm on call is I don't even want to take a call or even talk to a patient until I get a photograph. I said, go take a selfie or have your spouse or somebody in your family take a good picture and then text it to me. And he texted it to me. And what I see is, yeah, he has got quite a bit of hemorrhage here. I'm going to say probably about 40%. And he's telling me his vision is getting better. So that tells me it's actually probably settling up. So he probably had about a 50 or 60% hyphema. And that's why he really couldn't see. So that, Greg, that leads me to polling question number 2. This is not a problem because hyphema commonly occurs after eye stent. Not a problem because blurred vision is from corneal edema. Problem because the IOL dislocated. Or it's a problem, but I'm not really sure why.
So you had a question roll in. This would be a good time to take care of that.
Yep.
It says
Yep.
it's for the case before. Legally, what would we need to do for follow-up? If they don't go to the ER stroke center, just document you said to go? Question mark.
The answer is yes. We can't force a patient to have good health care. We can only offer them to have good health care. So we can't force them, but we document what we did. And if I have a place where I sent them, I said I actually wrote Sarasota Memorial Hospital. I wrote down what the urgency was, and hopefully off he went. Now maybe I should try to reach out and see whatever happened, but he is not the most responsive individual. Not a bad guy, but just not responsive.
I think documentation is enough. A lot of times what I write in the chart is RBQA, risk benefits questions answered, kind of put everything down Joe said, and then, maybe follow up with a phone call from the office. The staff reached out the next day. It's about all you can do, just to kind of show the concern. But like Joe said, you can't force them, and it just document as much as you can. All right.
So what do we
So
think? What are our responses?
So let me display it. We have the winner being problem, but I'm not sure why. It's 70%. And your runner up is not a problem because hyphema commonly occurs after eye stent. That's 23. And then a problem because the IOL is dislocated is 5%. And you had a taker on the not a problem because blurred vision is from cornea edema.
Well, I think we've all seen some degree of hyphema after a MIGS procedure, but Greg, what your experience? What is the level of hyphema that you usually see? I mean,
Yeah, it's certainly
always.
not that amount, 50%. We do a lot of Cahook dual blades. I've seen them maybe get to 10%. They seem to clot pretty good. The eye stents will bleed, but you don't have that you don't have that trabecular meshwork missing like in a Cahook dual blade. So, they get a little hyphema. I really haven't seen, like 40% or 50% that you were describing there. So, um, you know, you can get them. I mean, there's some intracranial issues that can cause them, but from mixed procedures is what you asked, so minimal. So
Well, sometimes we have to ask the question, not how red is the eye, but how is the eye red? We take a look at this eye and everything is pretty white and quiet. We come over here. Now, this isn't redness that you would see from a drug toxicity after cataract surgery or corneal abrasion or something like that. We can see the vessels are pretty dilated and they are kind of corkscrewed. We can kind of see it mostly in this area, some here. I don't know about the rest. Maybe he did. I mean, whoever took the picture, I think did a very good job, and this was sufficient for me to make some recommendations. And what we're dealing here with is basically a low flow cavernous sinus fistula. Now, I didn't see the patient before surgery, so I'm hoping we didn't put an eye stent into an eye with a cavernous sinus fistula. I'm suspecting that it probably developed coincidentally during the procedure from whatever trauma he may have gone through. But what we have to look at not is how red is the eye, but how is the eye red? We see these dilated, tortuous corkscrew episcleral and conjunctival vessels. We see it kind of go toward the limbus and turn back in what is known as an omega loop. And we see all the clear intervening conjunctiva. Now, neuroimaging and really good neuroimaging for a patient where we're suspecting this would be a CTA or an MRA because we're dealing with something arterial. And when dealing with something arterial, we want to have an A in the test, either CTA or MRA. Now, this is a patient I saw a long time ago. The patient would end up in an ER, and you can see that she has this markedly dilated superior ophthalmic vein, and that was really indicative of a cavernous sinus fistula. That was another patient. So what is the cavernous sinus? It's this trabeculated venous cavern on each side of the sella. And it has some pretty important anatomic features. It's got cranial nerve 3, 4, 6, first division of the fifth cranial nerve, the oculosympathetics, and the internal carotid artery. So there's a lot of neuroanatomy going in there. So this drains the eye and adnexa by the inferior superior ophthalmic vein, collects in the sinus, and goes out through the inferior petrosal sinuses to the jugular vein. Now, a fistula is just an abnormal communication from one structure to another. It's a rupture of the internal carotid artery or one of the small branches within the cavernous sinus. And what happens is arterial blood, which is very oxygenated and high pressure, mixes in the venous system, which is deoxygenated and low pressure. So if we look at it anatomically, this is the internal carotid artery, we get the 6, V1, 4, 3, a lot of stuff going on through there, and the oculosympathetics travel here. So the blood is draining from the eye and adnexa into this area, and then it just percolates out. Now I take a look here. This is the cavernous sinus. These are the superior and inferior ophthalmic veins, drains in here, inferior petrosal sinus going to the jugular vein. All right, depicted in blue, deoxygenated blood. The carotid artery goes through here. It just travels through. Doesn't mix, or shouldn't mix. But if something happens where there's a rent or tear in this artery or one of the small arteries, we're going to get high pressure oxygenated arterial blood in this venous system. It's going to expand it. Blood's going to go this way, and it's also going to go back this way. There's no veins, no valves here, so it can go retrograde back to the eyeball. Now, aqueous is going to be flowing from the secretory neuroepithelium of the ciliary body through the pupil. It's going to drain into the trabecular meshwork, Schlemm's canal, episcleral venous system, and then into the superior ophthalmic vein. Now, if blood is really high pressure, it's going to go back in this direction. So instead of aqueous going here, blood's going to be coming back out here. Glug, 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 filling the anterior chamber. And that is likely what happened in this patient. Now, these are characterized different ways. There's hemodynamically, either a high flow, where you get a tear in the artery, and this is a really bad situation, but this is major trauma, right? This doesn't happen spontaneously. This is an automobile accident, motorcycle accident, major head trauma. Low flow is one of these small branches that rupture and starts to trickle out. Now, probably little aneurysms have formed. These are kind of fairly common in middle-aged hypertensive females. Angiographically, either the internal carotid artery or one of the small branches, or did it happen spontaneously like this, or did it happen traumatically like this? Now, of course, there are external carotid artery branches which can also be involved, but they happen much less often. This is a nice example of a traumatic fistula, like after a car accident, a motorcycle accident. This is not a person you have to worry about walking into your office. They are going to be in the emergency room. This is going to be sight threatening. They probably will not retain vision in this eye. Fortunately, it's generally not life threatening. The ones that we're going to see are these chronic red eyes. These are people who have gone from doctor to doctor to get treated for their eye that just doesn't get clear any longer. It doesn't clear up. The antibiotics and the steroids and the antihistamines, nothing seemed to work for these patients. Now it's going to be increased venous pressure. The orbit will get very congested. You can get a pulsatile proptosis. I've never seen that in a low flow fistula, nor have I seen corneal exposure. Those are more the traumatic fistulas. But you will see arterialization of the conjunctival and episcleral vessels, sometimes called caput medusae, after Medusa's head of snakes. They may actually hear the heartbeat in their eye. And you can get myopathies and neuropathies with double vision, usually 6-nerve paresis, and secondary glaucoma because everything is backing up. And if episcleral venous pressure goes up, IOP is going to reflexly go up. And this is a tough type of pressure to control. If you're ever wondering or concerned or think about it, put the gonial lens on. A telltale sign of these low flow fistulas would be seeing blood in Schlemm's canal. You put the gonial lens on, you can see blood in Schlemm's canal, you know you've got some backup going on. Now they're vision threatening, but they're not life threatening. Spontaneous ones, as they come, they often will go. They can actually spontaneously resolve. There has been some recommendation to do internal carotid compression with your contralateral hand, trying to create some turbulence, like, over several minutes. Try to create some turbulence to maybe get that thing to seal up spontaneously. I do know of cases where changing cabin pressure on an airline was enough to seal one of these things. If that doesn't work, the larger ones are going to be stented. They can actually put a stent in there, but the smaller ones, like we see here, too small for a stent. What they'll probably do is a particular microembolization of the vessel, trying to just shut it off. But again, interventional angiography, you've got to get something up there and into this vessel to try to embolize it, and the risk of cerebral embolization is actually fairly high. So the glaucoma that occurs is episcleral venous pressure dependent. Prostaglandin analogs are episcleral venous pressure independent. They're about the only ones that will generally work in a situation like this. So beware of the chronic red eye. Dilated and tortuous episcleral vessels that go to limbus and back, what we call these omega loops, with intervening clear conjunctiva, or a red eye that just doesn't respond to treatment. They got what I call bagomeds. 2 antibiotics, 3 steroids, 5 artificial tears, and 2 antihistamines. So these are people that can have this disease chronically, and they don't recognize what's happening, and ultimately they probably need to be consulted with a vascular surgeon. Now that's a lot of stuff to remember, so I'm gonna make it easy for my ode to a fistula. Beware the chronic red eye. It isn't infected, inflamed, or dry. When corkscrew vessels make the eye red and the patient has bagomed, the problem is deep and arterial blood has begun to seep. Your first fistula you will always miss, but your second case you'll never be remiss. Every physician misses their first case of this, but again, you'll be alerted to it. You'll never miss your second case. Greg, anything come into the chat?
Good timing. I just opened it up and the chat is quiet.
All right, very good. Hopefully people are hanging. Now I'm going to do a series of cases here. 52-year-old male of a similar etiology. 52-year-old male, last eye exam was about 2 years ago. It wasn't dilated at that time. But he notices a peripheral blind spot, worse in his left eye, mostly when driving. Now, when he looks to his left, to his rear view mirror, he has some challenges, or side view mirror. No change in overall acuity, and the only activity of daily living he has difficulty with now is driving. Glasses don't seem to help improve his blind spot. It's 20/20 each eye, pupils are normal, no afferent defect. Exam is normal, it's 0.2 by 2, pink and distinct nerves. And this was seen by another practitioner in my practice. And she ran a full field 120-point screening. And we can see, based upon this, he got very few lights right. Mostly he's got a very, very constricted visual field or very poor visual field. And one may even start to conjecture, is this a malingering visual field or there's really just nothing there? So my colleague called me. She said, I don't know, I don't feel comfortable with this at this point. Will you take over and see this patient for me? I said, certainly. Now, I myself don't like the screening fields. The first thing I'm going to do is a formal perimetry, threshold perimetry. And if we look just down the total and pattern deviation, we're going to be lost. But what we do is we look at the gray scale. And what we see is a very dense hemianopic defect to the left side. We can see why he has difficulty driving and seeing his side view mirror. And this is pretty compelling. And this is a patient that's going to need neuroimaging. He's going to need brain with and without contrast. And what comes back is he had a very large suprasellar mass compressing, displacing the chiasm and posterior displacement of the midbrain. Now, the differentials include a macroadenoma with infarct, which is a pituitary apoplexy, epidermoid cyst, cranial pharyngioma, and he did have some mild hydrocephalus. Ultimately, what happened was, and I did lose, he was lost to follow-up. I got him referred to a neurosurgeon. He underwent a craniotomy, had a near complete removal of the tumor. They couldn't get all of it. I never saw or spoke to him again, but his wife called twice to just leave a message of how thankful she was that I found her husband's brain tumor. So here, I put this up here because this is your resource slide. If you want to take a picture, here's some, I think, very important clinical pearls. Full field 120-point screening is not helpful. Doesn't do anything for me. What we saw here in this case, it was not helpful at all. Also, a 30-2 is no better than a 24-2. When dealing with neuro-op disease, it's not going to help me anymore. And we're not looking for early glaucoma field defects. CETA standard is not needed. Use a fast. I use CETA fast on all these patients because neuro-op is not subtle. I want to get it done as quickly as we can. And look at the doggone grayscale. That is going to be incredibly important. We have all been told, don't look at the grayscale. It's not worth anything. It's where you put your coffee cup. With neuroophthalmic disease, it'll show you patterns that the total and pattern deviation will not show you. Greg,
Joe,
anything coming?
let me make
Go
a
right ahead.
comment on just kind of the reverse of that for those that are doing glaucoma, is that you can do CETA fast or CETA standard. When the patient's new to glaucoma, I think I'd probably recommend CETA standard because it crosses over the threshold twice. So you're looking for little decibel changes. Then as they graduate, maybe you could go to CETA faster as they're understanding. So remember, CETA standard crosses the threshold twice. So they can see it, can't see it, can't see it, can see it. They crossed it twice, so it helps narrow down the decibels. So that's just another way of saying doing it for your glaucoma, but another way of saying that you really don't need that kind of decibel sensitivity when it comes to neuro-op. Just get it across, see if it's where it is, see if it's respecting midlines, horizontals, verticals, and get her done quick, like Joe said.
Screening field, not helpful. Threshold, grayscale, helpful. Well, the next patient is a 68-year-old male who undergoes cataract surgery in our practice. He was not my patient initially. Developed a little capsular haze, got yagged. He ended up 20/25 in each eye, but he was not happy. And I have here, vision is worse now than before my surgery. Bright lights bother me. I'm missing letters when I read. And I clipped that. I did a copy and paste right out of my medical record or medical record. So it's all caps. So that implies he was yelling at the technicians. He feel his surgery was botched. Now, his exam was normal. Post-op care was unremarkable. Was seen by the optometrist in our practice, who was his patient. Yeah, he couldn't figure out what was. He wasn't comfortable with what was wrong. Patient wasn't happy. Refers to our retinal specialist, and he found a few drusen, some RPE changes, a little VMT, but didn't explain his why he was so unhappy. So he thought maybe he had an old non-arteritic ischemic neuropathy, so he recommended neuro referral, which was to me. He refers the neuro to me to work up. And usually when I see patients, that the last two things they have yet to be done, they have not been done is perimetry and consulting a psychic. So we do it. We don't really we look at the pattern deviation, but again, look at the grayscale. What does he have? He has got a right hemianopic defect. So this is another intracranial suspicion. So we have to go looking for it. MRI, brain with and without contrast with gadolinium. What does he find? He has got a lobulated cystic lesion exerting mass effect on the left optic pathways. By the way, when we talk to the radiologist and we think, let's say, for example, the patient has a right superior quadrant defect, and we think temporal lobe. We don't tell them to look in the temporal lobe. We tell them that it's affecting the left visual pathway, because things can be in different areas and moving other things across the midline. So we're not necessarily looking for something in the area, but something affecting the area. So this is a mass effect on the left optic pathway. There's a 4 millimeter midline shift, which is pretty serious. At 5 millimeters, you can have a seizure and die. Most suggestive of a suprasellar arachnoid cyst. So now we have an intracranial mass lesion here. Now, when I order these tests, I'm responsible for the patient now. He needs neurosurgery. I can tell you this was a challenge for some unknown reason. This was a challenge that getting him into a neurosurgeon who was willing to help. It probably had to refer several times. One or two officers said there's a 6-month wait, and my response is he may not be alive, so can we get him a little bit sooner? He did go to one neurosurgeon who he said walked in, looked at the film, said I can't help you, and walked out, and that was his report. Now, Greg, I only saw this patient one time, but I felt like I saw him a lot because I was talking to him on the phone all the time. And I was trying to get him into some neurosurgeon, and we'd have a conversation that would start off very nicely, and it would devolve into, I can't see. I had cataract surgery. Why can't I see? And he understood he had a lesion in his brain affecting his visual pathway, and he understood that, but he always come back to, and it always devolved to, but I can't see after cataract surgery, and it was very challenging. And this is one of those people that I had his name on a yellow sticky pad on my desk to remind myself to check in on him every now and then. And I was about to check in on him one day, and I got a card in the mail. It was actually from a person who lived in the same house with this patient. And he updated me, thanked me for taking care of this patient, of his friend, and he did have cataract surgery. He did have brain surgery. He did have neurosurgery, and sometime after the procedure, he died. Now, the way it was sent in the card didn't say he died from the surgery, from complications of the surgery. It said he died from conditions and variables after the surgery, which I thought was kind of odd. A way to put it, not complications of the surgery, but conditions and variables following surgery. I thought that was odd. So, Greg, I don't know if you ever do this, but when I have a patient that they know passes away, sometimes I will just Google them because I want to see their obituary and learn a little bit about the person. So I did that, and what happened was his obituary didn't come up, but everything that came up related to a prison record. And if I found out that he had done about 10 years in prison for something very, very bad prior to my seeing him. And when I put that together with the note that I got, I surmise he probably committed suicide. Anything there, Greg? Any thoughts, comments?
No thoughts or comments.
All right.
Let me check the chat box, and you are all caught up.
All right. Well, 33-year-old male has occipital headaches for about 4 months. He has a visual aura with his headaches. He is actually a dental student when I was at Nova. And he'd sit in class all day, and when he stood up, his headache got worse. Relieved by sleep, no vision loss, no nausea, no double vision, no pain on eye movements, no behavioral changes. So he goes to one of the PCPs and the internists at our medical school there. He does a age appropriate physical and says, "Well, you got headaches. You go see the eye doctor." So I saw him, and he's 20/20 in each eye with a myopic correction. Everything and neuroocular screening was unremarkable. Pressure to 12. He had normal nerves, slightly nasally oblique inserted, no pallor, no disc edema. And here is his visual field. Now, when we take a look at this, field is done, field is clear. He's got headaches. Generally speaking, our thought process is, well, we do a field and we don't find anything, and we feel pretty good that we have obviated that there's no ocular cause here. But going back, let's think about what's going on. He's got this headache for about 4 months, a chronic daily headache, and it worsens when he changes position. Does relieve by sleep, chronic daily headache, but this possibly changing headaches a little bit unusual. So I actually encountered the primary care, the internist who referred the patient. We had a conversation, and we agreed to co-manage. I suggested a battery of serological things that he was going to order, and I also suggested, because of the headache, we should probably get neuroimaging as well. Even though his nerves are fine, his vision is fine, his visual fields are fine, and something very similar, this is the representative image, shows up like this. So everything was fine until the MRI comes back. You need an MRI with and without contrast, brain and orbits. He had a large frontal parietal mass, worse more on one side, causing midline shift. This is not his image, but is pretty representative of what he had. So he had a very, very large brain tumor. It just was not affecting the visual pathway. So ultimately, the internist got him admitted to the hospital and onto anti-seizure medicines and steroids. He underwent neurosurgery. It was surgically removed. He underwent 2 rounds of chemotherapy and successfully went back to dental school. And he actually set up a practice in Tampa. And I remember, Greg, I was telling my residents this case, and I thought about it, and I thought to myself, wonder how he's doing. So I wanted to Google his name to see where he's practicing in Tampa, because he did graduate the dental school and start a dental practice. And the first thing came up was a link to his obituary. He died about 5 years after I had seen him from brain cancer. So here's a clinical pearl for everybody. A normal visual field does not mean there is anything wrong. It just means the visual system has not been impacted. He had a massive brain tumor, did not affect the visual field. So if we do fields and it comes back clean, we feel good, doesn't mean there's not anything wrong. It just means that the visual pathway has not been impacted. Now here's a case, 39-year-old male. This happened during COVID lockdown. I actually did this remotely with one of my former residents. 39-year-old male has a history of migraine, and he develops lethargy and a new worsening headache. He went to the hospital ER. They had a non-contrast enhanced CT and MRI of the head, both non-contrast. Both were interpreted as normal. He had been admitted 3 days. Ultimately, he was diagnosed as having migraine, which is a pre-existing diagnosis. He was given a new migraine medicine and discharged. Now, 3 days later, he develops a horizontal and vertical double vision. So let's take a look at how he is. He's got a little bit of ptosis here, maybe a little bit of an exodeviation. He cannot abduct his eye, and he cannot adduct his eye. So ptosis, abduction deficit. Now, we're all in lockdown. This was an emergency that went to the office of one of my former residents who got caught in the weeds in this one and reached out to me for help to get some suggestions. And what I'm always going to tell anybody who has a double vision patient, I'm going to say, please go and film the motilities and send them to me via text. So let's just take a look at them. Got a little ptosis. Abduction deficit, maybe some elevation deficits there. So I've looked at this. I call my former resident, very sweet guy, and I asked him, "Are you doing EOMs or playing with a cat toy?" And it looks like he's chasing a cat toy. I said, "Go back and just do the physiological H for me." So he goes back, and we seem to just do an up and down, up and down, up and down. Can you go left or right, please? Left or right? And just left or right, please. All right. So I'm not getting anything here at this point. I kind of gave up. All right, maybe it doesn't look down so well. So let's start talking about what's dealing here. Acuity is fine. So go back and do a visual field. He tells me the visual field's fine. He's got right pupil sparing, partial third nerve palsy, sixth nerve palsy, worsening headache, and lethargy. So where is the lesion? Where are 3 and 6 going to come together? They're going to come together in the cavernous sinus or the posterior orbit. Now in the posterior orbit, you got cranial nerve 2. His vision is good, so I am really thinking about the cavernous sinus. So with my former resident, let's contact the hospital radiology department and have the radiologist look at it again. And there's no harm in that. It happens all the time. If you have some questions, ask the radiologist to take a second look, but tell that person what you're looking for. And I specifically said, please examine carefully the cavernous sinus on the right side. So he does, and he comes back and then looks at it and he said, well, the cavernous sinus is fine. But the pituitary gland looks a little bit chubby, at which point I knew what we're dealing with. Well, getting back to the emergency for a contrast enhancement of the MRI of the paracellular area and an MRA, because we're looking for an intracavernous aneurysm and or pituitary apoplexy, and that's what he had. When they looked again with contrast, specifically in the proper area, he had a pituitary macroadenoma that had hemorrhage and blew up like a blood balloon. So he had pituitary apoplexy. It spread into the right cavernous sinus at this point, now spreading into the left cavernous sinus, but it wasn't moving superiorly, so it wasn't affecting the optic nerve or the chiasm. So the visual function was actually good. That's why his acuity and fields were good. Ultimately, he is admitted immediately for endocrinological and neurosurgical evaluation. But again, this is COVID lockdown. Nobody wants to do surgery on a person, on anybody at this point. But what is pituitary apoplexy? It's a severe and potentially fatal condition in about 10% of pituitary adenomas. They're going to have headache, they can have vomiting, they can have abdominal paresis, they can have vision loss, altered mental state, altered consciousness, lethargy, all from panhypopituitarism. This is a potentially fatal disease. One of the few things that we cannot afford to miss ophthalmically. Hemodynamic instability, they have no adrenocorticotrophic hormone. It can be fatal, they can die. Now, this is from a rapid expansion of a pre-existing, but might be an unknown adenoma. But it's a rapid expansion, and that's why the headache is so severe and sudden. They can have cranial nerve palsies. They often will have visual field defects. Typically, they'll have a bitemporal hemianoptic defect. Now, if we look at the anatomy, there's the chiasm above. This is the soloturcica, this pituitary gland. We have the cavernous sinus on each side. They can go superior, they can expand this way, giving you a new onset, rapid onset bitemporal defect, or can spread laterally, giving you multiple cranial nerve palsies, which is what happened in this patient. Or it can go in both directions, above and lateral. So these things will blow up like blood balloons. Most common symptom, bad headache. It is a frontal or retroorbital, but it is a bad headache. It's bad enough for this migrainer to go to the emergency room. And apoplexy is often overlooked as a potential cause of these really bad thunderclap headaches because they're really looking for a subarachnoid hemorrhage, a venous sinus thrombosis, or a cervical artery dissection. Now, about half the patients will have visual abnormalities, meaning half don't. Cranial nerve palsies are very common. Visual field defects are very common, usually a bitemporal defect. And a lot of times patients will have a pituitary adenoma they do not know about, and it suddenly expands infarcts or hemorrhages. Now, most of these bad headache patients will undergo a non-contrast enhanced CT in the emergency room because they're looking for an acute intracranial hemorrhage. Now, if it is hemorrhagic, they might find it on a CT, but if it's infarctive and not hemorrhagic, it's not going to show unless they do contrast. Really, the imaging is MRI contrasts when you suspect pituitary apoplexy, and MRI is much better than a CT. Fortunately, these patients can do it can be fatal, but they can also do quite well if it's diagnosed. Conservative medical treatment is usually going to be initiated. What they're going to do is they're going to try to replace the missing pituitary hormones. And ultimately, they'll undergo a surgical decompression to remove the adenoma and all that now clotted blood. If they have visual impairment or neuro-ophthalmic issues such as double vision, they're going to have to undergo surgery. Now, this patient was medically stabilized because it was COVID lockdown. Nobody wanted to do surgery. So they admitted him, they stabilized him, then they released him and watched him. And once COVID lockdown was lifted, he underwent transfemoral surgery, and he had a very successful surgical decompression and successful outcome with return of all his motilities. Now, the question is, why was this missed? A couple of reasons. One, it wasn't directed. They were non-contrast. They weren't looking for this. They weren't thinking of this. And probably it evolved over time. It probably evolved over the course of a week. It didn't suddenly expand like a huge balloon, but it probably evolved over a period of time. Anything there, Greg?
Hey, Joe, a question came in
Good.
asking, by chance, was the testosterone low?
I don't think I got into the weeds on that one. I don't think so, but I could be wrong about that.
That was it? You're
Next,
caught up?
46-year-old female referred from one of my former residents in our referral network for new or sudden onset blurred vision in the right eye for about a month. No pain. She's missing a piece of her vision. She's got no double vision, no head pain. She thinks she might have had COVID a week before she lost her vision, but she never tested for it, so she doesn't know. She's just making a supposition. Just over-the-counter medicines for heartburn, and she's complaining of this non-specific vision loss. Now, she had left side head trauma from a fall about a year ago. I think that's a red herring. She noted her vision loss about a month ago and feels like it's gotten progressively worse. No pain in eye movements. Contact lens 2200, but she pinholed a 2060, 2020 the other eye. She's got a marked afferent defect in the right eye. Her cupping is about 6 by 6 in each eye, obliquely inserted, no pallor or edema. Color vision, she's depressed in the right eye, normal in the left eye, and her fundus and macular OCT are all normal. And this is what she looks like. Moderately large nerves, slightly rotated a little bit, some parapapillary atrophy, about a 0.6 cup, no disc pallor. That's just an oblique insertion there. And we can see on the OCT, everything is good in the neurofiber layer and ganglion cell complex, which we'll come back to later as an important part of the story. Her visual field, essentially normal left eye, and we have an inferior defect in the right eye. Not unexpected. So that brings me to polling question number 3, Greg. What's the likely diagnosis? Does she have optic neuritis, neuromyelitis optica spectrum disorder, myelin oligodendrocyte glycoprotein antibody disease, non-arteritic ischemic neuropathy, infection, infiltration, or does she have a compressive lesion? This is going to be a bit of a tough one.
Okay, answers are rolling in. Polling
All right.
question is open. Let me check that chat box. Nope. So
Now
so
let's just treat. I didn't talk about this, and they're not that common or commonly known. So let's consider 2 and 3 to be all part of optic neuritis. So let's bring optic neuritis, NMO, and MOGAD to be more or less the same thing, at least for now.
all right, let's see how we're doing here. Did I lose it? There it is. All right. Looks like people are rolling in, making not as many responses here. Think they're thinking about it.
Little tougher.
All right. So the trends look like they're set. It looks like the winner is going to be non-arteritic anterior ischemic optic neuropathy at 29%, unless you add optic neuritis and your NMOSD and your MOGAD together, because they were 26, 10, and 18. And then infiltration is 5, and compressive is 10%, and infection is 0.
All right. Well, let's work through this one. Let's take a second look. She got a painless loss of vision that she thinks is getting worse over the past month. Now, I didn't force the history. We just had a good conversation. And when I was talking to her, she started to acknowledge that she did feel she was having trouble with her right contact lens. She kept replacing it. And now she acknowledges that her vision loss may have been actually longer than the past month, and she thought she was really just having a contact lens related problem. So maybe maybe it isn't as sudden as we think, or going even further. And that's what I was kind of looking for, because all the others here did not put wind in my sails. So ultimately, we're going to have to look at the optic nerve. So we are going to do MRI brain and orbits with and without contrast. Please rule out demyelinization, compression, infiltration, right optic neuropathy. Please perform both studies, brain orbits chiasm with contrast. And it comes back, there's a mass effect on the optic chiasm to display superiorly. Let's see what here. No evidence of invasion of the cavernous sinus. The mass displaces portions of the prechiasmic right optic nerve laterally. So the optic nerve's involved and the chiasm's involved. So ultimately, mass effect on the prechiasmic right optic nerve and chiasm, as detailed above. Most likely a planum sphenoidal meningioma. So she actually had a mass lesion. And this was not nearly as sudden as she seemed to have thought. And that was my suspicion. This progressive painless vision loss did not seem to be anything that was really acute. I thought it really probably was there. And these are mass lesions that are really pretty frontal, and they can actually involve the frontal lobe and give some personality change. Now, she did not have anything of that sort. She did not have a flat affect, but these will create some issues on the visual pathway and the chiasm. So these sphenoidal meningiomas arrive from, from the or often called olfactory groove meningiomas, and they are in the midline anterior cranial fossa. And they're about 10% of all intracranial meningiomas. Now, because it could involve the frontal lobe, they may actually have some cognitive dysfunction or sometimes like a flat affect. And they can have vision loss later, and it's going to displace the frontal lobes and compress the optic chiasm. And of course, these are most commonly going to be treated with surgery. Now, question, why wasn't it optic neuritis or these NMO or MOGAD? Well, that's a painful disease, and she had painless vision loss, and that really doesn't fit. And non-arteritic ischemic neuropathy, she's a bit on the young side, but she didn't have that disc at risk. She had very big cups, so that is not a risk factor for non-arteritic. And just talking with her, and I had the sense that we're dealing with a compressive lesion. Now, it took about 4 months to get her into the right place and taken care of, but she did have a craniotomy. I did offer this to our local orbital neurosurgeons, but they passed because the chiasm and internal carotid artery involvement. They did help connect me with a top skull-based surgeon at University of South Florida, Tampa General. Now, the tumor is wrapped very tightly around the optic nerve, so he had to leave a little bit of the tumor. And what he told her was, it's been there about 10 years. He said if we did nothing, it would cross over and affect your other eye, and you'd ultimately become bilaterally blind. So after surgery, I saw her about 6 months later. As the don't fall through the cracks follow-up visit. She comes back. She tells me she feels better. Her vision seems better, less dim. It's not quite as bright as the other eye, but there's no afferent defect pupil now. I didn't do contrast sensitivity. I didn't do color testing, but now her vision's improved to 20/15 in each eye. And this is preoperatively when I made the diagnosis, and this is postoperatively. You see what happened. She got better, and I was anticipating this. And why I was anticipating this? Let's go back to what her structure was. Even though she had functional loss, her structure was really good. When the structure is good, there's a very good chance these compressive lesions, if they're successfully removed, can actually have improvement in function. Now, if there is abnormalities in the neurofibrillary layer and the ganglion cell complex, I would probably tell her I don't expect to have any vision recovery. I did tell her I think if this is successful surgery, I think you will actually have some visual recovery, and I was correct because this was normal to start with. Okay, now guys, buckle your seatbelts, brace for impact. You're not going to like what I'm about to say next. All right. I've just spent the last, I don't know, however many minutes talking about some cases. Here's your resource slide. If you want to take a picture of this, go right ahead. Let me summarize. I just talked about 5 mass lesions. All right. Let me summarize them for you. Vision was normal in 4 cases, abnormal in 1 case. Vertical field loss in 2 cases. 2 cases had normal visual fields. 1 case had unilateral loss. There's headache in 2 cases. No headache in 3 cases. Double vision and ophthalmoparesis, 1 case, not in 4 cases. No disc pallor in any case. No disc edema in any case. No papilledema in any case. Conclusion: intracranial mass lesions do not follow expected rules. If you think a patient is going to come in saying they wake up with nausea and vomiting, massive headache, you look in and you see champagne corks in the vitreous, that's not going to happen. I mean, that's brain tumor. That's not going to happen in every case. Mass lesions don't follow any anticipated or expected rules. You have to keep your mind open to this possibility in all these patients. Greg, any comments or anything coming in the chat?
Let me check. Nope, nothing's there. You're caught up.
All right. But I know people don't like to see this, and it's scary. But the brain tumor patient, the mass lesion patient, they're not going to come in stereotypical. They're not going to have champagne corks in the vitreous and headache and vomiting and everything like that, and vertical field defects. It can be anything. All right, 48-year-old female. Sudden painful vision loss in her right eye, about 2 days duration. She went to the ER where they did a non-contrast enhanced CT of the head. Why? Because it's what they do. And it was normal. She went to her PCP. Her PCP diagnosed zoster because of this retroorbital pain, prescribed Valtrex and prednisone, but the patient didn't use either of them because she didn't think she had zoster. She didn't agree with the diagnosis. But very commonly, the PCP refers the patient to our office for an eye exam to rule out any ophthalmic involvement of herpes, which is a good thing. All right, good thing. So she's diagnosed based upon her temporal head pain, but there's no lesions. There's no dermatologic lesions, and a lot of our PCPs, Greg, I'm sure this happens in your area. They refer a patient for an eye exam to make sure there's no ocular involvement. They know what they're doing. They make good diagnoses, except in this case. Anyway, she comes in. She's 20/60 right eye, 20/20 left eye. She's got an afferent defect in the right eye. She's 14 out of 14 in each eye, but she struggles in her right eye with color vision testing. And she has this retroorbital and temporal pain, which is the genesis of her zoster diagnosis. Now, here are her optic nerves. We can see that they are small. They are not edematous. They are not pale. They look actually pretty normal. Nothing really happening in the left eye, but we do have a pretty distinct visual field defect corresponding to a normal looking optic nerve and an afferent defect. So plan MRI brain orbits and chiasm with gadolinium and suppression of the orbits. And here's what she comes back with. Edema enhancement, both optic nerves, optic nerve thickening, worse on the right, suspicious for optic neuritis. Fairly extensive non-enhancing punctate and confluent foci of abnormal T2 prolongation, probably about the lateral ventricles, oriented perpendicular to lateral ventricles, raising the possibility of demyelination with optic neuritis. All right, so we've done the MRI, and now we have our findings. Now, she is a very astute patient, and she's going to come back and she's going to ask me some questions that I'm going to have to answer. She's going to ask me, are you sure it's optic neuritis? Well, there's pain. There's an afferent defect. She's female. There's no disc edema, and there is MRI enhancement. So this is retrobulbar, all right? If it looks like a duck, swims like a duck, and quacks like a duck, probably is a duck. So the answer is yes, I am sure it's optic neuritis. Now she's going to ask, is it isolated demyelinating optic neuritis, or is it clinically isolated syndrome? Now she's going to ask, is it isolated demyelinating optic neuritis or isolated optic neuritis? Now, if she comes back and uses the term clinically isolated syndrome, I am immediately uncomfortable because she probably knows more about this than I do. Then she's going to ask the question, do I have multiple sclerosis? Greg, that will be our next polling question. Does she have multiple sclerosis? Yes? No? Or I don't know.
Polling question is open. Let me check that chat box. It's quiet. Back to the polling question. It is open.
So this is what her MRI of the orbits and brain shows me. So my polling question and her question to me is, does she have multiple sclerosis? And I can tell you when she asked me when she asked me that question, I'm going to roll. How are trends coming, Greg?
Trends are good. You're trending. I'm going to let a couple more roll in. Okay. Yes, 36%. No, 6%. The winner is 59% of I don't know.
That's actually probably the best answer to give right now. I know I'm not going to answer that question. I know neuro-ophthalmologists who are not going to answer that question. That's really a question for a neurologist who is specifically skilled in demyelinating disease. But let's talk about this. Does she have multiple sclerosis? I don't know. But I can talk to what's your risk of developing multiple sclerosis? And the question is, should I be treated? All right, let's answer all these now. So demyelinating optic neuritis is a inflammatory demyelinating event in the optic nerve. Can be idiopathic, involving only the optic nerve, or it can be associated with some other systemic illness. And usually it's multiple sclerosis. Now, 90% of demyelinating disease is demyelinating optic neuritis is MS. But about 10% are NMOSD and MOGAD. These are the new kids on the block that we have to consider. About a third will have a papillitis, 2/3 will be retrobulbar. Abrupt vision loss is about 20/60 on average, but anywhere from 20/20 to no light perception. There's an afferent defect, there's dyschromatopsia, decreased brightness and contrast. It usually gets worse through about 2 weeks, and it does recover, but there may be some deficits. And it's usually Caucasian, very rare in Asians or people of color. And I say here 92% have pain. That comes from the optic neuritis treatment trial. That's, in my opinion, not accurate. All these patients have pain. The 8% that didn't have pain in this study were misdiagnoses. We'll talk about that in just a bit. Now, my experience is what brings patients in is pain and dyschromatopsia. They notice something is wrong. There's a lot of receptors that go into color vision. So it is usually thrown off first. And the pain. The vision loss may be mild, and that's usually not what brings them in. Now, optic neuritis is usually painful, sometimes not, but that is a misdiagnosis. Anybody using the term occult optic neuritis, meaning that they tell a patient you probably had optic neuritis, but you just didn't know about it, is really saying, I don't understand this disease. It is a pain. This is not a subtle disease that a reasonable person is going to not know they have. Now, the optic neuritis treatment trial looked at 15 centers, about 457 acute optic neuritis patients, and they were treated with oral prednisone, IV methylprednisolone, followed by oral prednisone, or an oral placebo. Now, at 6 months, everybody showed good recovery of vision. People in the IV group got their vision back faster, but by day 30, the differences was insignificant. But the problem was the oral prednisone group were more likely to experience recurrent optic neuritis than the other groups, and they are more likely to progress on to clinically definite multiple sclerosis. And it probably isn't the route of administration, it's the fact that the dose was probably too low. Now, visual function after treated or untreated optic neuritis usually is going to start to recover within about 2 weeks of it starting. Most of the recovery is going to be after 1 month, by 1 month, and they can still recover vision and everything up to about a year. Now, if they're not getting better within about the first week after the starts, you got to consider this is very atypical and you may not have the right diagnosis. Now, demyelinating optic neuritis, the MRI is critical in diagnosis and management and knowing what to do. Now, the 15-year result of the optic neuritis treatment trial, overall, about half the patients in the study converted to clinically definite multiple sclerosis. Now, if they had a normal MRI at baseline, there's a 25% chance that they would convert. If it was abnormal at baseline, which this woman had, there's a 75% chance. Now, she ultimately was diagnosed by a neurologist as having multiple sclerosis. Now, in this study, the lowest risk of conversion to MS were men Those who had swollen optic nerves, who had no pain, and no light perception vision. These are all likely misdiagnoses. They had some other occult neuropathy, but got put into the study. So when you hear that 92% of people had pain from this disease in this study, really the ones who truly had optic neuritis, they all had pain. So men, papillitis, swollen nerve, no pain, no light perception vision. These are the ones who really didn't convert to multiple sclerosis because they had something else. Now, normal MRI at baseline and no MS at 10 years, then there's only a 2% risk at 15 years. And we diagnose by looking at focal demyelinating lesions separated by time or space. Now, Greg, when I was training, and we had what we thought was an optic neuritis patient, we did everything we could to not diagnose it. We tried to rule out everything else, but we didn't want to make a diagnosis of optic neuritis because of the relationship with multiple sclerosis and the fact that there is no treatment at that time. So we were a don't ask, don't tell type of approach. Now we've got these immunomodulatories, these biologic agents, the interferon therapies, and these really alter the course of the disease and slow the accumulation of disabilities. So there's actually a penalty for not starting treatment early. So we have gone from a don't ask, don't tell to a get the patient diagnosed as quickly as you can and into the hands of a skilled neurologist so that they can get the treatments that they need. So the paradigm has changed dramatically. Was it like that when you were training, Greg? Because you were just a few years after me.
Yep, yep. And it was a few years after, nothing really changed. But I agree, the paradigm has shifted to
Mhm.
get them into these biologic agents.
Now here's another patient, 45-year-old female, different patient. On an April, 1 year in April, I saw her for a comprehensive eye exam. Now she already had a diagnosis of MS. She's been diagnosed, but she's not under any treatment, is not following with a neurologist. She had been on Capoxone and interferon, but had not been using for the past several years since her last pregnancy. So I see her and she is normal, except she has some snow banking in the retinas, both eyes, suggestive of an old pars planitis, which is pretty commonly associated with multiple sclerosis. Now, 4 months later, she comes back with vision blur for several days in her left eye, with left eye pain, worse with eye movement. Interestingly, there's only a one letter difference on the 20/20 line in her left eye, and her issue is kind of the pain. And she does have an afferent defect. We look at the optic nerve. We can see the right nerve is pretty pristine. The left eye has got some acute swelling that goes along with it. If you notice, there are no hemorrhages at all. You do not get disc hemorrhages in patients with optic neuritis. If you see a disc hemorrhage, you need to rethink the diagnosis. Now we take a look here on the OCT, everything is fine in the right eye, left eye, very, very hot because of the juxtapapillary edema. We can see the swelling of the optic nerve right there. This eye is nice. We can see that that swollen area of the optic nerve shows up beautifully here. This may or may not be real. I did not repeat it, but this one is, I think, fairly compelling. Matches her optic nerve issues. So she has evidence of demyelinating optic neuritis. It looks like a duck, swims like a duck, quacks like a duck. It probably is a duck. And this tells you how there's penalty for non-treatment. So I didn't do any neuroimaging here. She has a history. It does look very suspicious for it. I just reconnected with her past neurologist. You know, she had not followed up with him. Now she's on Ocrevus infusion every 6 months, which has been approved for relapsing and remitting multiple sclerosis and progressive multiple sclerosis. I've seen her for three successive annual exams. She's been normal every time and has no accumulation of disabilities. So hence there is a penalty for non-treatment in some of these patients. Now, diagnosing MS can be very challenging. There's always demyelinating events disseminate in time or space. time, two or more events at different times, or brain MRI lesions seen as old or new. Now, when she underwent her MRI, my first patient, the 47-year-old, she had some fresh lesions. Now, if she had some old lesions on the MRI, which the radiologist can identify, she could have been diagnosed with MS at that time. Disseminating in space, two or more events at different neurological areas. Now, there's something known as the clinically isolated syndrome, and we talked about that. That's an inflammatory demyelinating episode in the central nervous system, like an optic neuritis. Neuroimaging is often normal. It doesn't necessarily indicate MS conversion, but a person with MS who has had more than one episode, but 63% of these will go on to clinically definite MS. So you can have an isolated optic neuritis with normal imaging, and we call that just a clinically isolated syndrome. We don't say that there has been a diagnosis of MS yet. Now, diagnosing MS, and this is why we need neurologists really skilled in this disease. There's the McDonald criteria. There's 2010 and 2017. Now, these patients will undergo CSF analysis from spinal tap, looking for these inflammatory proteins called oligoclonal bands. If they are in the CSF of a patient who's being worked up for MS, is a very important diagnostic criteria. In 2017, the presence of these oligoclonal bands, these inflammatory proteins in the CSF, they were included in to be allowed for the definition of a diagnosis of MS. So prior to that, 2010, you had more unknown cases than you had known cases. You had more clinically isolated cases that we just didn't know. Now they said, yeah, if you do a spinal tap and these proteins are there, that counts. Now, when you add them in, the diagnosis of MS goes up and the unknowns go down. And why is this important? Well, now they can be diagnosed with MS. They can be availed of the treatments that they need, and insurance will cover these treatments because it is a diagnosis of clinically definite MS. So adding this CSF analysis brought the unknown cases down and helped neurologists to make diagnosis of MS earlier. Now, the only problem is in that criteria, optic nerve didn't count. So we have always thought that we as eye doctors, optometrists, ophthalmologists can look at a patient with optic neuritis, we diagnose and say, you've got MS, and we're done. That's a huge disservice because it's not right. Optic nerve couldn't be involved. Right? You could not, they could, optic nerve was not allowed to be part of the diagnostic criteria of MS. Disseminating space, one or more lesions in two or more of the areas of the CNS, periventricular, cortical, juxtacortical, infratentorial brain regions, and the spinal cord. You had to have lesions there. Optic nerve didn't count. Now, neurologists, they encounter these cases, they couldn't use the optic neuritis to make a diagnosis of MS, and studies have shown that if you put the optic nerve involved, it actually increases your ability to diagnose MS. So if they were to add the anatomic nerve, the optic nerve as an anatomic site, this can actually increase the diagnosis of MS and reduce the clinically isolated I don't know cases. So any optic nerve by MRI, OCT, or visual evoked potential can actually increase the diagnostic aptitude for this disease. Now, this is brand new. 2025, this was just published last month. Now the new criteria actually includes optic nerve as a fifth topographical site. So now you can it's easier to meet the dissemination and space requirement. So, but there has to be evidence of optic nerve involvement from either MRI, it enhances, or OCT, or visually evoked potentials. So this can identify silent damage and give us an early diagnosis of MS. OCT is now very important in this diagnosis. So the 5 areas now for diagnosing disseminating space: optic nerve, periventricular, cortical juxtacortical, infratentorial brain regions, and the spinal cord. So there's 5 places where you have demyelinating lesions that help make the diagnosis. Now, the optic nerve, you have to have MRI enhancement or OCT abnormalities. Now, on OCT is an inter-eye difference in the RNFL of more than 6 microns or more than 4 microns in the GCC. And this allows for asymptomatic optic nerve involvement. Now, patients with MS can have a thinned nerve fibrillary and ganglion cell complex without ever having optic neuritis. So I'm not talking asymptomatic optic neuritis. That doesn't happen. But you can have asymptomatic thinning of the nerve fibrillary and ganglion cell complex in MS without ever having had optic neuritis. So to make the criteria, they have to have lesions on 2 of the 5 spots, but that does now include optic nerve. And this is going to enhance diagnostic processes, especially for people with what's been known as clinically isolated syndrome. So optic nerve is going to speed, and now that we can actually use optic nerve as a diagnostic criteria, it's going to speed up the diagnosis, earlier treatment. Now here's a patient, and I've got to watch my time. Not sure how far we're going to get, Greg. 42-year-old male. I saw him probably within the last several months. Now he comes in, he had a history of optic neuritis 10 years ago. Now this is, I've never seen him, but he and his wife come in, he's got this history, optic neuritis 10 years ago. When I talked with him, he said he had painless, total vision loss in his left eye. It took about 2 months to come back. So male, painless, he said no light perception in that eye, took about 2 months to come back. He had an MRI, it was reportedly clear of MS. There are no demyelinating lesions. So what are we dealing with here? Probably a clinically isolated syndrome. Now, patient had a stroke 3 weeks before I saw him. Another MRI was done, and the result showed no demyelinating issues. And he was advised to follow up with a neuro eye specialist, and he came to me. He feels his vision is adequate. Now, he's 20/20 right eye, left eye. He has no afferent pupillary defect. He has got good visual fields, but we can certainly see on the OCT, he's got a normal OCT and a very abnormal in the right eye and a very abnormal one in the left eye. So what the question we have to ask is, what is the diagnosis? Is this MS? Well, he has had imaging. He is 10 years out. He does not have clinically definite MS. So what do we call this? We'd have to call this an isolated optic neuritis, although I'm suspicious, or a clinically isolated syndrome. So what is his prognosis? All right, he's got a normal brain MRI at baseline. He's 10 years out. What's going to be his risk of developing multiple sclerosis at 15 years? Well, his risk is about 2%. So what is the significance of the OCT now in the future? It can actually show us these issues, and this can now count as optic nerve involvement and meet one of the criteria for multiple sclerosis. Now, the interesting thing here, as I was chatting with him, I felt I had some really good news. You know, I mean, I know I can tell you only have a 2% risk of developing MS in the next 5 years. And I thought he and his wife would be really, really happy about it. But Greg, I tell you, what they said was, oh yeah, this happened. We haven't even thought twice about it. So what I told them, good news, made no difference to them whatsoever. But I thought it was good news. Greg, anything coming in?
Let me take a look. Nope. Last question was the testosterone question.
All right. Well, I have a ton more material that I'm not going to get to, so we're going to have to roll that into some other lecture. But I will touch. I only have a couple minutes, so I'm going to touch on these other players: the neuromyelitis optica spectrum disorder and the MOGAD disease. These are demyelinating diseases, a lot like MS, but they're rarer. In fact, NMOSD there's only about 22,000 cases in the US. But every now and then we would see a patient with MS that just had a very, very, very poor course and did very, very, very poorly, and we never really knew why. And the reason we didn't know is we didn't really understand that there was a separate condition. This is an optic nerve optic neuritis. Also involves the spinal cord, it's a transverse myelitis. Now they have high levels of this antibody, aquaporin 4 antibody, are antibodies against the transmembrane water channel protein, the CNS, on the astrocytic end feet. So it demyelinates the optic nerve and the spinal cord in a different way than multiple sclerosis does. Now, median age of onset is about 39, a little bit later than MS. It's very strong female preponderance, but is more prevalent in Asians and African Americans, whereas multiple sclerosis is more Caucasian. If it's African American or Asian, we need to think more about this. Now, some of these people can be seronegative, but it's a relapsing and often progressive course. And it's got a very bad prognosis. The vision is usually going to end up less than 2200. Optic neuritis is usually better than 2040. This is often going to be worse than 2200. It can be bilateral and simultaneous, which is very uncommon in MS. And the MRI is going to be very helpful. It's going to be very long involvement of the optic nerve, and it can often be bilateral. So it's very extensive. Whereas MS, there's like little areas of optic nerve enhancement. This is a long extension involving a lot of the optic nerve and chiasm. Now, treatment is different than MS. They need high-dose steroids right away. Plasma exchange can be done, plasmapheresis. And early treatment is really pretty important in reducing risk of visual morbidity and overall morbidity. And these are people who are going to need long-term immunosuppressive therapy. So what we have to do is we have to consider ordering these antibodies, the aquaporin 4 antibodies. So whenever I deal with suspected optic neuritis, I'm also going to be ordering aquaporin 4 antibodies, and I'm going to be ordering myelin oligodendrocyte antibodies as well. MOGAD is a protein on the myelin sheath, and these antibodies in MOGAD disease are going to attack these proteins. So this is how this disease demyelinates. It's about 5% of optic neuritis cases. It's not really a very common disease, but when dealing with suspected optic neuritis, where now I will always order anti-MOG antibodies. And this is often very common in children as well. So I think that that brings me about, I was going to talk about non-arteritic ischemic neuropathy, but we're going to talk about that in another lecture. So I think we've gone about long enough at this point, Greg. What are your thoughts? About time to wrap it up?
Well, we had someone ask a question here. How long does it take to get to a good neuro-ophthalmology?
Neuro-ophthalmologists or neurologists who have skills in what we're looking for. The reality is it helps if you can form relationships and they know you. Now, in my area, I have a good relationship with the relatively small neuro-ophthalmic community we have here. If I send a text, I'm going to get a text right back. They trust me. If there's a patient I want them to see immediately, they'll work the patient in the next day or so. But it comes from doing the same thing and being in the same in kind of the same field, and we have a good relationship. But if you sometimes it just involves reaching out, tell them what you think, what you have, and they can help facilitate seeing a patient. Otherwise, it's 6 months to get in.
I'm going to just remind the audience that the little red dot has appeared right there. It says survey. You can click there to start the survey that we need. Please complete that because we need that for our regulatory bodies. Jim or Joe, Jacob is what I'm trying to say here, is excited for part two if it comes to fruition. So I think you'll probably will that to fruition. And your virtual, good lecture is starting to roll in. And that is the last, those are the last comments and the questions that are in the chat box. There are no other polling questions. Any final comments before I wrap this up, Joe?
No, I've been doing nothing but commenting for the last hour and 40 minutes. I think I have said enough. I think they have heard more than enough from me at this point. I'm quite satisfied to let you wrap this up. But I thank everybody for listening. I've got probably 2 or 3 more neuro op lectures that are new with new cases and new learning that I'm putting together right now. So I'm looking forward to doing that. And we'll be talking about non-arteritic anterior ischemic. Actually, Greg, we're eventually we're going to be talking about all 3 types of anterior ischemic optic neuropathy. There's arteritic anterior ischemic optic neuropathy, non-arteritic anterior ischemic optic neuropathy, and non-arteritic anterior ischemic optic neuropathy. And I'll explain what that is, I guess, next time we do a lecture.
Okay, that's a good little cliffhanger for those to return. As I mentioned in the opening remarks, Joe's talented in many ways, writing, speaking, and has really taken neuro
Oh,
to the next level. Go ahead, Joe.
I just looked at the chat. How long did it take you to get so good? And they asked how long. I thought how long it takes to get into neuro. How long did it take me to get so good? Yeah, 30 some years.
Yeah, practicing
It's
30
it,
years. Right?
yeah, it's taken all this time. And I've actually developed an interest in this, and I've grown somewhat bored with glaucoma. I used to do every lecture was glaucoma, and I've just switched to neuro.
Yeah, another neuro disease, but taking it to the next level. So with that said, Joe, questions are answered. Thank you for doing it. As I mentioned in the opening remarks, that Joe's a gifted writer. He's very gifted at other ocular diseases, but neuro is taking it to the next level, and that was highlighted tonight. And you're getting your thank you. So everyone, thank you for attending. Cranial Conundrums, Clinical Pearls for Clinical Disease. This was a synchronous virtual course. This will wrap up the education.